Good afternoon, everybody. It's Friday. It's the 20th of May, and you're here at Lunch and Learn. Today is a sort of a general topic. We're going to talk about brain zaps and other interesting sort of things that people sense. This came up during one of our previous, I think, Lunch and Learns, where people were talking about various either sort of side effects or experiences people have, and the term brain zaps came up. And I certainly know I've worked with people who've described having these little quote brain zaps. So we're going to talk about that and other interesting phenomena that may occur. And so I'm going to turn over to Richard to get started. Richard.
Thanks, Rob. This is an old topic that Rob and I have been talking about since the Stone Age, when we started doing these lunch and learns, and we noticed it, and it's been noted. People were noticing it back in the early 2000s, and they began to refer to as iatrogenic effects. And I think Corey Hammond took the lead, as I recall, in identifying these things and discussing them. And there was a lot of confusion about it. And at first, there was because it was so close to the 20th century, there was the traditional, oh, well, it's just, it's all just in their head. It's a psychological phenomenon. We don't know why, but it's akin to dissociative processes and conversion disorder. So I think most people who were formally trained in psychology were thinking, well, this is kind of a conversion phenomenon. Although in the field of psychology, conversion is a very highly controversial thing. How much do people convert a trauma into physical feelings? And I think van der Kolk hopefully hammered the psychiatric community with his book on The Body Keeps the Score and got them to, at least those who read it, wake up and realize the validity of it. And he actually traces a lot of it, because that was the whole theme of the book. People with trauma experience things in their body, and he goes into the research on why, who did that research, how they came to the conclusions. He was ground zero when all that stuff was being researched and coming out, and but it was not really spoken of. He was in a little corner of the universe then. His voice wasn't even heard until the 21st century, really. But they were doing all kinds of experiments and research to try to understand how people convert, that energy from the trauma. And it's a very Freudian psychodynamic idea, which is probably why it wasn't very popular in psychology, because after the 60s, everybody was, had physics envy. They wanted to have a research approach that was reductionist and just like physics and experimental. And psychiatry wanted the same thing. I mean, they got hold of drugs and suddenly they got a lot of money and grants and labs, and their pay went up. And so the psychiatric community just fully embraced drugs and dropped everything else practically. And in the middle, this were people like van der Kolk and the whole community that he was involved with. A small community of people are saying that, wait a second, there's a lot more to this than just giving people drugs. We got to understand this whole qualitative side to this. And it's like, UFOs, oh, they don't exist. They can't. It was just bias. Oh, those feelings people have in their body, oh, it's all in their mind, because it's coming from the medical model. And the psychodynamic model, Freudian model, was discounted. So it was just like nobody wanted to talk about it, nobody wanted to deal with it. But clinicians like van der Kolk and all these people were seeing it. He would say, people come into my office and they have all these strange sensory and smell issues and body issues. They have all these problems around food. And he would go on and on, tics and things like that that came and went. And of course, there was a whole community of people who were talking about it and writing about it to some degree. So Now, along comes neurofeedback, which is a mixed mash of everybody on planet Earth who got interested in brainwaves, showing up in the late 90s at meetings and in the early 20th century. And people like Corey Hammond he was professor, and he was trying to well, we've got to codify this and make sense of it. And he used the medical model because he was working at a medical university and started talking about iatrogenic effects and publishing articles in uh, ISNR and doing presentations on it. But it was still kind of, like UFOs, but those of us who were doing neurofeedback with people with complex trauma, and they didn't have that term back then. We were thinking PTSD and traumatic brain injury. I can remember in the 90s, traumatic brain injury was considered a fantasy by most people in neurology, and they hated the term. And complex trauma that didn't exist. PTSD didn't get entered in until I think the 1980, diagnostic 3 or 4. I'm trying to remember. I think it was 3. And so that was kind of brand new kid on the street, and nobody really took that very seriously. So we're all in neurofeedback, doing neurofeedback on people with brains and looking at electricity coming out of the brain. And we're saying, well, when we train people, they're getting these iatrogenic effects. We didn't want to use the term side effects because that made neurofeedback look like drugs, and then that confused everybody. Plus, you had all these people saying, there you go. Neurofeedback creates side effects. It's like a drug. You shouldn't be using it. It's dangerous. And then out of the other corner of the mouth, they would say, but it's a complete placebo effect. So they're really saying the same thing. And there's no rationale. It's like saying, we got to stop all abortion, but it's okay if the baby starves to death in your arms afterwards. It's just people aren't putting it all together and thinking about it. It's just fear, professional fear, and the military saying there's no such thing as UFOs because they don't know what to do about it. Well, if there's PTSD, we don't know what to do about it. So we're dealing with this problem in the late 90s, and a lot of clinicians were discounting what was going on. But I think the majority of the people in our field were pretty open-minded, saying, we're getting a lot of weird effects. And Corey's saying, yeah, we are. Neurofeedback causes side effects. He went so far as to say, that if you don't use a brain map and you don't do exactly the right thing, you're going to hurt people. And that's not what van der Kolk was saying. But he wasn't publishing on it. And Corey was just using the best that he had to work with. I think a lot of us in the field were a little put off by the formality, intensity, and stringency of Hammond's arguments, that they were a little bit overreaching, because we were seeing that we were doing neurofeedback and these symptoms were abating, and that they weren't as destructive. They weren't exactly like drug side effects, and that they did seem to be grounded in people's trauma. And in alpha theta training especially, you'd see a ton of it. If you're doing alpha theta training, that's why a lot of people were afraid of alpha theta training. You start doing it, and they would start getting these iatrogenic effects all over the place. Well, it was emerging trauma. If you had read the literature on war trauma, like van der Kolk did, and I was reading literature on war trauma from Cambodia and the Vietnam War, and I was working with Vietnam vets. When you're reading that, families that people that saw their families tortured to death in front of them went blind, and the doctors, they could find no problem with them. And that was a surprise, in the 1980s and 90s. They're going like, wow, imagine that. Where Freud had already said from his research, he was a neurologist, or he was trained to be a neurologist, people were having loss of feeling and movement in their hands from the wrist down, which is impossible neurologically because that's not how the nerves work. And he was seeing a lot of other things, hysteria and all this other stuff. So we've known about it, but we've been denying it, like so many things we deny. You don't need to wash your hands when you're delivering babies. That's a lot of crap, until it turns out it wasn't. and it was life or death. So here we are getting into this thing with and we still haven't resolved it. I mean, you all are still asking us questions about this. It's still a major concern, and we don't really have anything written up more comprehensively. So since Rob's retired, I'm going to ask him to write an article on it.
Well, what I have done is I sent out 3 of Corey Hammond's articles for people to read in the meantime. It's on the listserv now.
Wow. So and and please don't panic when you read his articles. I mean, just that's why I said it. You know, some of it's a little overreaching, but it's very good stuff overall. And at least he was trying to deal with it in a very responsible way, as he always does.
Yeah,
And the fact is that we're still dealing with it, and we have to come to grips. And everybody here has different backgrounds. You have to come to grips with the fact, and it's the science is there now. We know it's real, but science has actually been there for 100 years. It's just that nobody wanted to really take it seriously. That people convert their trauma into physiological experience, but it's not that they just convert it. First of all, when you are traumatized, the majority of people brace. We know that from research and biofeedback's published 30 years of it. And it's also in psychological research going back to the 70s. We know that. I was reading it when I was a graduate student. And I was researching it as a graduate student. You brace, you tense up, and your level of arousal, sympathetic level of arousal, your baseline level is higher. And when it's higher, your whole sympathetic system is ramped up. Your immune function is inhibited. Your muscle tension globally is elevated. For women, it tends to also affect their arterial muscles, the smooth muscles, and more than men, and affect the peripheral vascularity. It affects your endocrine system, sweat gland response, your breathing changes. You learn to breathe differently. And people get pains just because they're tensing up all the time, builds up a lot of excess lactic acid. They move their body differently and in stereotypical terms, gets localized, and you get pains in your chest and so forth because your muscles get too tight because you're thoracically breathing. You get cramps in your leg because you're using up so much the lactic acid build, but also because magnesium deficits really increase, you start getting Charlie horses and more cramps. But that's just the beginning of the first layer of physiology. And the next layer is there's actually a somatic landscape, which Antonio Damasio first gave voice to and talked about in the 90s in Descartes' Error. And that's a brilliant book, wonderful readable book where he starts discussing all of this stuff. And then he wrote the book, The Feeling of What Happens, which interestingly enough, really influenced van der Kolk, because here's this world famous neurologist doing research who's saying, I'm working with these people and I can tell you for a fact that they're storing stuff differentially based on the trauma. Well, then comes along the research. I can remember in late 90s, early 2000s, I was reading articles where the neuroimaging community was saying, you know what, when people are traumatized, they can't put together the memories because it turns out, they found out, the memory system is not a unitary thing, but highly diffuse. And that memory is, you have smell memory, hearing memory, visual memory. And when you create a memory, you draw the memory from those separate memory systems, sensory systems, and in real time, you recombine them. And whenever you do that, you actually change your memory, which is why we all have crappy memory as a species. You alter that memory because you're adding new information when you do that. And part of it's just your response. And it was Joseph Ledoux doing work on the amygdala who found out, wait a second, you can't assemble a memory a lot of times. It gets stuck in implicit memory in those sensory memory areas because when you try to assemble it, your amygdala just goes crazy and it drives your system into a panic state. And because of that, you can't consolidate a memory, and you can't move it from the implicit to the explicit memory system. So I'm going over all of this research really fast, but it's a ton of it. And the different authors who were responsible for these ideas. So then you suddenly realize, oh, wait a second. This is in the body, in the somatic landscape, and it's in the sensory systems. And when you're traumatized, it gets stuck there, and we have a natural drive to try to integrate, because when it's stuck there, it shuts down pathways and the brain can't work properly. And the brain's always seeking to go to its allostatic state, optimal one, which they call homeostasis in the literature, unfortunately. But to try to get there, and so we have this innate drive to try to resolve trauma, because it causes, when it's not resolved, it causes all kinds of health problems and physical pains and so forth and so on. So when I first started doing alpha theta training, I would, I was dealing with people with severe childhood trauma, uh, torture in cults, that's children in ritual cults, and people who in Vietnam had seen just horrific things. Um, I couldn't believe, when I read Van der Kolk's book, I was like, yeah, I've been there, I've seen it. I mean, you can't believe the stories these people tell you. It's like, and you could probably see a lot of people going, that they're exaggerating. They aren't. These things really happened. As I would train people, they would say, oh, I had a strange smell that session. I didn't like it. Like, oh, I felt like I had a strange sensation on my body. I didn't like it. And we would talk about it a little bit at the end of each session. And almost with every single one of them, over a period of several sessions, they would recover a memory. And this was happening at the same time that memory recovery was being dissed by the psychological community, that it doesn't really exist. People don't have, there's not an unconscious. People don't have these memories from trauma, and counselors just get them to make it up. So it was very unpopular, but the neuroimaging community and everybody else was going like, I know this is real. But people in psychology don't read neuroimaging. And in counseling, they definitely don't. They do now, but not too recently. So then you have this problem uh, where you're seeing, and if you don't know it, people having these senses, you're just counting it. And some of the sensations are cold, hot, shock, buzzing. Some of the people were electrically shocked, literally. But the feeling of electrical shock shows up in a lot of syndromes and disorders, uh, and burning, like burning sensations over your whole body, or shocking sensations in your body. Those are real medical side effects of real medical diagnoses. So we know the nervous system can do that on its own just when it's imbalanced. So think of complex trauma, how imbalanced your system is. And you're training somebody and they're recovering these memories in pieces. And then all of a sudden they come together and they literally have a panic attack right in front of you during alpha theta sometimes when they remember the whole memory. And you have got to stabilize them. Um, and your goal, and what we knew back then, is you need to stabilize them and get them back in the alpha theta state. And of course now, we have Nicholson and Lanius and everybody in the latest research saying like, and even Van der Kolk saying like, if they can get through the memory in a and be in the present, and in complex trauma therapy, that's called the exposure. So you do like cognitive behavioral therapy and prepare them and train them to breathe and everything, just like alpha theta, except we were doing it decades ahead. And then after that, you have them bring up the idea and you expose them to it. And it can be external or internal. Lanius and Nicholson and all these other people are doing it with MRIs, exposing them while they watch their brains. You can see exactly what's going on in the networks and in the body. That's how real this is. And so these people who have trauma start to put it together, and they're having these different feelings And they aren't because the neurofeedback is making it happen because you put a sensor there and they're like, oh, my head feels like it's moving around, or I'm getting electrical feeling. It's not electricity from the sensors or the equipment. It's their body. It's natural body sensations we have when we're dealing with disease, disorder, or integrating trauma. And you can read the literature, it's there. So I'm just going on this long diatribe to give you a background, to understand it, to make some citations so that you can go look for yourself, and to kind of set up you up for this being a credible thing to discuss and something that's okay and that's going to happen and that you have to manage and deal with. So I get off my soapbox now and we can start getting up things that people have experienced. Tell us what you've seen, what you're concerned about, stories you have. Let's share this and see, how are you managing it? Because it's wide open. How do you manage it?
Yeah, I'll
Everybody.
start with sharing that I've had people report these brain zaps, like electrical little sensations in their brain. That has happened more often when I've done neurofeedback with people who have had head injuries. And the same thing with they feel sometimes like their brain is moving, actual like it's moving in their skull. Similarly, most commonly with people who've had some sort of a head injury. So those sort of odd effects that people or sensations, not effects from the neurofeedback, but sensations they tend to have. That's what I've experienced on several occasions from different patients, specifically with head injuries.
Yeah, head injury is a big
Yeah.
one, right?
Yeah, and I'll tell them that's okay. And once I've had that experience and checked it out and knew that I wasn't doing something wrong, then I just tell the patient that that's not uncommon at all to have those kinds of sensations. There's nothing wrong with that. It's just like, hormones in the brain. I've worked with several women who were going into a menopause and they're having hot flashes. And if you're running somebody, a woman who's having a hot flash, you're going to see it in your raw EEG there. You see something that looks unusual. So when I did it, I paused and I said, is there anything that you're experiencing? Oh, yeah, I'm having a hot flash. Okay, we'll carry on. That's okay.
Well, I think you really struck a nerve there though when you said, don't worry about it. It's part of just the process in a sense. It's okay, it'll pass. But you weren't just saying it about them, you were saying it about yourself as a therapist. As soon as I realized I wasn't doing anything wrong.
Oh yeah, yeah, yeah. I don't worry about that. Yeah, the very first time somebody reported those apps, I probably talked with you or somebody else, and got a sense of that's not an uncommon phenomenon. And you talk to others, and you go to conferences, and you find it. So yeah, then my response to them is, I'm not worried about this at all. These are not side effects from neurofeedback per se. They're individualized sensations that people have and maybe through the process of neurofeedback they experience those. It's not that it's causing it per se, and I'm not worried, and I tell them not to worry about it. We just carry on.
That's why I said, the electrical shocks are not shocks from the equipment.
Right. Exactly.
Which some people, I mean, if you're not really familiar with electronic theory, I mean, you could be concerned, and you can get a shock if your equipment's not working right. That's rare these days, but it did happen in the 90s. Um, where you get a sensor and things weren't grounded properly, and you'd get a little bit of a burning sensation on your scalp where the sensor was. So malfunctioning equipment can cause that, but it's not the same as the type of they're saying, well, it felt like a lightning bolt, or it felt like electricity, or it felt like I put my finger in the plug and I jumped back. I mean,
Yeah.
that's a neurological
Right.
response,
Yeah.
and it's coming from the equipment. And I remember at the meetings, people were going like, geez, what are these? Are we doing this? And there was a real concern that we might be doing, because it's just, these are counselors. These aren't experts in all these other areas. And that's why, Hammond started writing some articles saying, we need to look at this and make sure we aren't doing it. And maybe we are. I mean, just wasn't enough understood at the time. But now we know better. It's the same as when you relax somebody. I mean, if you look at what can happen when you relax somebody, they can have panic attacks, they can become depressed, they can have hallucinations, um, uh, they can have seizures. I mean, all kinds of things can happen when you relax people. Relaxing people is very dangerous. But the FDA says it's okay if you relax people. It's like, that's not what they consider harm, interestingly enough. So that still has to be put together too. But no, you aren't, it's not you doing it. So that's my main message here to you all as therapists, if you haven't already figured that out. You are not causing it directly with the equipment. You are causing it in a sense indirectly, because you are calming these people down. You're lowering their baseline arousal level, and they start to relax their muscles, and the heart rate changes and the breathing shifts. The body's going to go right away into re-experiencing past trauma or trying to integrate it. It's just how the human body works. And the side effects and the symptoms are just like the colors in the rainbow. There's so many of them, it's amazing. And it's very idiosyncratic. That would be my main message. Don't panic.
I haven't experienced anyone with brain zaps, but I've had smells.
Yes.
People talk a lot about, not a lot, a number of people have talked about smells.
That's because you're in Jersey. That place got all
that air. Yeah, that doesn't surprise me, Judy, with smells, because especially if you're opening up memory, our sense of smell is one of our strongest senses that's tied to memory. And so that would not surprise me at all if they said, I had this interesting smell of, a flower arrangement. I haven't recalled that smell since, my mother's funeral or something like that. Yeah.
And I don't know what kind of trauma population you deal with. You just may not have run into enough of a population of severely traumatized people. That's one possibility. I don't know for sure, but I know where I started off, boy, I was a ton of severely traumatized people, and I was like going like, wow, is the rest of the population like this? So we talked about brain zaps. Anybody have any, and smells? Anybody else experience other things or mysterious stuff they're not sure about?
I can tell you
Whoops, Diane, you just went out.
Yeah, come back.
Yeah, here I am. Just an interesting story about smell, just a personal experience I had to tell you how strong smell memory is.
Yeah.
I was in Woodstock, New York one time shopping with some girlfriends. And as a kid at age 9, my family's house burned down. And it was a really, really tough experience for a 9-year-old. And so anyway, so I remembered there was a lot of water and smoke and all that kind of stuff. So fast forward to like 5 years ago, walking around Woodstock with my girlfriends, walk into this shop, and I stood at the door and I was like totally, got, silent and just kind of standing there, and they go, "What's the matter?" And I go, "Oh my God, this place smells like wet smoke." And my girlfriends are looking at me and they're like, "What's in?" Because they smelled nothing whatsoever. So the woman at the cash register overheard me, and she said, "Did you just say this place smells like wet smoke?" And I said, "Yeah." And she said, "No one has ever walked in here and said that before." And she related that the building had burned down. Well, not burned down, but had been severely damaged, and it had smoke damage and water, etc., and that they had thought they had gotten all the smell out of the building, but my nose picked it up. So
Yeah.
that was a really amazing lesson at the power of your olfactory system
That was a lesson
relative
too,
to
correct.
trauma. Yeah.
Yep.
Nobody else smelled it. Yeah.
Yeah. I had a similar one, but it was as a kid, but it was not with smell, it was with taste. When I was a child, I don't recall them having baby aspirins that were orange flavored. And in the beginning of my childhood, I was not keen on swallowing pills. So I would chew things like aspirin, and aspirin has a very bitter taste. And as I'm talking to you as we speak about aspirin and thinking about that, my mouth is starting to water. I'm salivating. And that's what happens every time I think about aspirin.
There you go. That's a really interesting story. Yeah.
Yep.
I wanted to ask a question. Is the Dr. Suter, is the smell senses, do they not go through the hypothalamus for
I mean, the
sensory?
thalamus. No, the smell does not go through the thalamus. It's the only sensory one that doesn't.
So that's one of the things that's not necessarily integrated.
Yeah, it's
Sensory.
very primitive. It's very primitive. And that's why people have often said it's one of the most common responses to remember trauma is smell.
Interesting.
It
Well,
is.
one good note is this chiropractor that I was dealing with had a severe brain injury after a car accident, and he had sensory issues. He would get cold when he went outside, have to wear a jacket. And within 15 sessions of doing SMR at CZ, he reversed that. He started being able to self-regulate, which is very interesting. Anyway, sad story.
That's a great side story. And that brings up the point that when we were talking about this at several of the meetings about in Alpha Theta, people are doing presentations, you could almost set your watch by the that in terms of the time the speaker ended, and Siegfried would step up to the mic and say, "We see that with SMR and beta training and neurofeedback too." And he made sure we did not skip over that or forget it, because that was their paradigm, and they really didn't do much Alpha Theta themselves. But they wanted to make the point that you can integrate trauma with this beta SMR training. So I think that point shouldn't be lost either, that even if you're just doing SMR training on somebody, they can start to integrate trauma. In fact, if you take, a vet from Fallujah and just put them in a chair, which I've done, and in a relaxing environment, they'll start to have memories come back up. Yeah, flashbacks. And when that happens, they immediately become classically conditioned to the room and the flashback, and then they don't want to come back. That can often also happen to you with people with panic disorders. They come in, they have a panic attack in your office. They don't want to come back because every time they come to the office, it reminds them of the last panic attack they had, which is a real catch-22.
I've had that. I've had people have a fearful experience, or they didn't tolerate time, and they were, doing it was a gentle SMR, but that they had a big reaction to it, and then felt that they would have that every single time. That was a tough one to overcome.
Yeah, I mean, it can be a real catch-22.
Mm. Well, that also speaks to one of the reasons the three of us tend to promote training initially with, pretty simple calming protocols that are not likely to cause these. Not that one will never get one, but the chances are much less when you're doing like some SMR or working at C3, C4 in the motor strip. And so I think that speaks to that issue, as well as give people a little bit of a positive experience in the beginning, give them a little bit of a benefit, feeling a bit calmer, or maybe a little bit better night's sleep after a few sessions before we get into, other protocols.
Yeah, well, that's part of the international, a group that looks at complex trauma. The World Health Organization recognizes it, but the DSM doesn't. They subsume it under PTSD. And one of the key features in the recommendations is that you help people, you stabilize them in a sense. You help them prepare for exposure to the recovered memory, or if it's internal, or to the trigger if it's external, because part of the therapy is involved in both. So you're going to teach them how to breathe, through stress, how to relax, and you do all of these different techniques, and then you do cognitive behavioral therapy with them to help them learn how to manage the relationship between their thought and their emotions. Well, we've been doing, at least I've been teaching that for alpha theta training since 1998, I think, because that was in all the literature I was seeing in its seminal form, and that's what I was seeing in the clinic. But I wasn't the only one. I would go to meetings and other people saying, you know what, we're finding that alpha theta works better if you do regular neurofeedback up front. And then Bill Scott, who was pioneering all the research after Peniston, he was working with the Othmers, and he was like really into that. He said, they do that original work and then they send them to me and things go much better. And so they, in the field of neurofeedback in the 90s, we're doing what's just being recommended now and recognized now. I mean, that's how far ahead of everybody we typically are in this field. So don't underestimate the field of neurofeedback. Just because we don't have a lot of giant, special control group designs, 60% of which in medicine are invalid because they don't do them right, and their findings are all wrong. Now we have a drug epidemic. Don't underestimate the field and what people are finding. When you go to a meeting, it's amazing to talk to fellow clinicians. There's a lot of brilliant people who are very observant and very skilled. And we talk about this stuff. And they knew that. And it has been standard in the field. You should do, relaxation training, HRV training, and standard neurofeedback to help people stabilize and integrate and get them ready for what may occur in the alpha theta experience, where they're going to start recovering memories. When you start putting them into a liminal state, twilight state, it comes up. There's no way out of it. And when it comes up, if they're not prepared, it's really rough on them and on you, and you'll have a higher dropout rate, and you may even re-traumatize them. So that's why you don't just jump into alpha theta training. That's why I say you do 15 or 20 sessions of neurofeedback, and you're not getting good integration, and people aren't really getting much better, and they're still having cognitive problems. Odds are, statistically, that you're dealing with complex trauma. And there's a lot of statistics to support that out there, going back decades at this point. So you're going to be doing alpha theta training. And if you aren't, you're not going to be making much more progress, especially if you don't recognize you're dealing with complex trauma. And especially if you don't have somebody to refer to, or you haven't taken some CEU courses yourself in how to manage it, which you can do, and any good therapist can learn to do with the workshops and some some people oversight, people mentoring you through it. You can learn to be very good, very quick, but especially if you've been a therapist for a long time. So when you do the alpha theta training, the person is prepared. And so training people ahead of time is important. And what Siegfried was doing and trying to get people to realize is that stuff that was coming out, their type of training back then was an important component of preparing people before they handed them off to Bill Scott, or before you and your clinic did alpha theta. So that, and everybody was talking about that. We all kind of knew that. But you always got people who want to reinvent the wheel and come in and just slap people on alpha theta and say it worked, and they got lucky for a while until somebody blew up on them, and then they stopped doing alpha theta, or they got in trouble with the board, or something happened. So there's no reason for it. Soapbox number 2.
I was thinking, I wonder whether or not I often with complex trauma will do the reactivity protocols of Fisher in different sites for a while before I move to alpha theta. And I wonder if because the limbic system is less active and less activated, might that account for why I'm not getting unpleasant flashbacks?
I think you're probably right, based upon Nicholson's latest research, and Lanius works with Nicholson a lot, and some other people she's worked with who published prior to that. They've set up, a whole paradigm that they're building on. That's exactly what they're seeing in terms of the activity in the brain. If you can calm them down directly, you can reduce the symptomology profoundly, which is what you talk about all the time, right? I mean,
Yep.
you love that T4.
I do. T4 minus P4.
Mm-hmm.
T3 minus T4, O1 minus O2. There's a number of sites that I'll like run them through and drop frequency on and then move them to alpha theta, because everybody gets alpha theta, probably 10 sessions at the end of it. And they have they have usually a great experience.
I think that's a good model, and I think you're kind of pioneering that inadvertently, because people tend to just do Fisher or Lanius protocol, and which was technically all the Othmer protocol originally, and doing that as and along with counseling, CBT, or
counseling, of course.
There's 2 other therapies that are recommended. Some people use EMDR with it, which is also very effective. So you use those combinations, they're very powerful. And I think probably every individual responds differently to different combinations, like everything else. We're not going to get one set way that everybody has to do it, and that's the only way that works. There's too many different kinds of people with different kinds of physiologies and genetics out there. But I think you're right. And looking at the research that was just posted last year, that's a very convincing argument. My concern about what Nicholson and Lanius are proposing, which you're going beyond, Judy, and because you're a therapist and they aren't, and I would never discount that if I were you, with a lot of experience, is that everybody in the field of complex trauma knows the standard is 10 to 20 years before you resolve complex trauma. And then we have these researchers saying, oh, well, we've resolved it in 10 or 20 sessions completely. And I'm going to let,
I cannot even imagine 10 or 20 sessions doing it. Like I never sit down with people, and I'm talking about 50 or 60, to be honest. When I don't, that's how I explain it.
Researchers are claiming, and this is the problem with people being exclusively in research without enough clinical experience. The 2 sides have to talk. They got that one trauma down, but in another month or 6 months, the second one or the second group's going to come up. That's why it's complex, right?
Mm-hmm, mm-hmm.
And so they're saying, oh, we've solved this problem. And it's like, no, you haven't. I think Judy's beginning to solve the problem, but they haven't. So technically, I think you're ahead of them, Judy.
I don't. I mean,
You don't
I
like
wouldn't.
that idea, right?
I don't know. Yeah, like I feel too not. I am not worthy to say that. But what I do know, I've really gotten over these last few weeks this feeling that our field has so much change going on all the time that all we can hope to do is the best we can with what we know at the time and be safe about what we're trying to do. And that's really been very comforting to me, because I'm doing what I know. I'm basing you know, how they feel, where I'm going. I'm using, you know, it's not cookie cutter, it's patient
Oh.
related.
Mm-hmm.
And you know, I love it, Richard, when you've been saying over the last couple of weeks, we don't exactly know why that is. We don't really know why this is. And there are some things, and I just know how much we don't know.
Yeah.
So,
Judy,
you know,
Judy, let me restate something. Perhaps maybe you're not following behind the medical community as much as to say you're leading, as Dr.
thank you.
Seuss.
I don't really want to, I'm
Keep you
so
humble.
not a leader in this.
Hey,
Thank you,
Judy,
Rodney.
I had the same sentiment when I started, when I did my first few years in this field. I think Rob did too. It's just like, oh, well, I'm just learning here. And all of a sudden you find out that you've learned so much that you're actually innovating. And the innovating, without knowing it, is paralleling what's being found in the research because you're using very empirical methods and techniques and you're staying close to the research. So inadvertently, you're just trying to help your clients, but you're anticipating without intention what the research is finding. And that's, I think, what happens when you're doing clinical work properly with good empirical approaches, good assessment tools with neurofeedback. I think it's unavoidable.
I would say about 20 to 25% of my client population I'm doing some sort of trauma work with. It's a
Yeah.
good amount of people that come in. I map everybody anyway, and then I have to have a double conversation about this is what I would do if I was treating you based on what your map shows. However, this from what you've said seems to make more sense. Like the 18-year-old girl I just worked with who was being bullied and on drugs, antidepressants in elementary school, tried to hang herself at 12, was raped, and 6 months later, her father was killed in a motorcycle accident.
Oh my God.
Now, should I treat anxiety and depression that the map shows? I mean, it doesn't make as much sense to me as working to try some of this calming of her limbic system, you know? So this just makes sense. I think as a therapist, I worked years with people with whatever we were calling it of the time, the PTSD. I mean, I early on went to Christine Courtois workshops and Judith Herman workshops and Bessel in his early day workshops just to know. And this was, you know, so when I saw the Fisher work, that's why I'm so drawn to it, you know, because it fits with how I see, you know, and putting it together with what we're doing, you know, I think people are doing great.
Well, when you look at the incidence rate of trauma in the world, a survey was conducted in 24 countries, and you can Google it. 70% of the respondents experienced one trauma event and 30.5% experienced 4 or more events. Now, you probably get slightly different figures depending on whether you go to WHO or what different, but that 30.5% makes sense because that's also the rate of anxiety and depression in the general population. And a fair amount of those people have it, anxiety and depression, because they've had multiple traumatic events.
Mm-hmm.
And if you define it as toxic stress, that fits perfectly in with their estimate of incidence rate and leading to the problems in the population with health. So that's pretty, and near in a clinic, so you can probably double that rate. So maybe 40% of people coming in your clinic at least minimally have complex trauma.
Mm-hmm.
I'm just, you know, ballparking it, but that's what we should expect.
Well, that's a good note to end on.
Mm-hmm. I somehow bring the conversation around to trauma too often, I think sometimes here. That's not where we were in the beginning, but you know, just
But it ties
so
into the
my
topic. So,
yeah.
you
Yeah.
know, I
Well,
mean,
the problem
because
is,
trauma, go ahead, Richard, go ahead.
I was going to say, the problem is it's like trying to talk about health problems without talking about inflammation. And eventually you end up talking about inflammation.
Good point. Good point. So
And as
Monday
we
night,
noted,
I'm very excited about Monday night because I need some help understanding more about how this Klonopin is affecting the work I'm doing. I want to hear more about that. So that's why we've got the topic benzos and how neurofeedback doesn't get the job done sometimes. I want to understand that more.
And
So
those
I
of
can,
you who
I
want to
want
do
to,
homework,
yeah,
if
go ahead.
those of you who want to do homework, get Anatomy of an Epidemic and read it
Yeah.
Oh yeah.
over the weekend. It's
Mm.
an amazing read.
I want to
Yeah.
be able to explain it to clients, what happens, and, you know, because I can't expect them if they've been on it for 20 years to go off it, but can I do my job, you know?
Oh
So
yeah,
I'm
it's a great
excited
topic.
about Monday.
Okay,
All right,
bye.
folks, I got to
See you
run.
Monday
We'll see
night.
you Monday night. Bye-bye.
Bye.
Bye-bye.